Okay, guys, this is chapter 26, soft tissue injuries. Bringing this bad boy up and we'll get started on this. Soft tissue injuries has a lot to do with some of the splinting supplies that I noticed y'all were working on today. It also is going to look at open versus closed injuries, but soft tissue is the integumentary system. It is the skin. They're pretty common injuries. They can be, when we get to avulsions or some different openings, a lot of bleeding, it can be distracting, but again, just know we're still focusing airway, breathing, circulation, and of course, we're going to manage this in the appropriate means. There's different ways that we'll manage each of these injuries, and we'll look at some of those as we move through it. But different mechanisms, right? Mechanism of injury, we saw that in the trauma overview, but it could be a blunt injury. So again, something that just bruises or bashes against the skin, a penetrating injury, something that's actually pierced the skin itself, barotrauma, changes in pressure, and then burns. So again, those are kind of four different types we're gonna look through. The common form of injury, soft tissue, again, you fall down and you bruise your arm. That is technically a soft tissue injury. The prevent, again, as far as taking some of these soft tissue injuries can often be prevented by simple protective actions as we look through them. But as far as death is concerned, the most common cause of death from a soft tissue injury is uncontrolled insanguination. That just means they bleed. And it's actually why you've been approved to use the tourniquet, because a laceration to the arm that's bleeding out the brachial artery, people can lose a lot of blood. So again, there's no wrong way to stop these life-threatening bleeds. And I will give you a disclaimer right now. As I'm in this room, I did notice for probably 5 minutes of remaining still. Maybe I'll have to do this to make sure the lights stay on. But if that happens, we didn't go dark on you. I'll make sure I get those back on. But I'm not going to pause and do this. It's kind of like we're just in the classroom, right? Something happens, move around, the light comes back on. Awesome. So I've given you full disclaimers about that. But obviously your skin or the integumentary system, first line of defense, right? Infection, if you have an open cut or a sore, we always make sure we put gloves on. That's preventing you from hopefully transmitting some disease or getting into your skin. And it also protects against, well, it can be the elements, it can be something that falls and hits your skin. Okay, it's going to protect you from those external forces. It is pretty tough. As far as the skin is concerned, it just depends on the amount of force and pressure that's actually applied to it and whether or not we're going to have an injury. So keep it in mind in all of these soft tissue injuries, making sure we control bleeding. And again, that can be through different forms of direct pressure, elevation, potentially pressure dressings. And when it comes down to it, actually the tourniquet, the preventing further contamination. So again, if someone has this massive amount of road rash, think about it, all that skin is open. That's how they become susceptible to this disease or the infection. So we prevent further damage by bandaging these things appropriately. Another example is if you're dealing with the neck and there's an open wound in there, then that air can actually rush in. It can lead to cardiac arrest or an air embolism. So that's why we want to make sure we're protecting those, how much bleeding or actual separation of that skin has actually happened. The epidermis and the dermis, again, those two different layers. I know there's some pictures coming up with that you can actually see, right? This is your epidermis. Your epidermis is showing, everybody learned that in 3rd grade. If you didn't, there you go now. So it's the tougher external layer of your skin versus the dermis is that inner layer. And here we go, one of the pictures I was talking about. And when you look at what's contained within each of those areas, right? The epidermis versus the dermis. We should even continue down just to be aware that the subcutaneous tissue is there, that how, when you look at someone's injury, you may actually notice, oh, I can see this. I can see, bits of fat as it's gone down that low, but that's something that would be included in your assessment as you're starting to evaluate the patient and the degree of trauma that they've actually suffered. The Skin does all external surfaces of your body. Again, right? That's just that full protection that you're offered. Again, the difference between the skin and a bodily opening is that that bodily opening is actually lined with mucous membranes, right? Your mouth's got those, your nose has those, but the skin itself is just that big protective layer. The skin and the functions that it does serve, it's responsible for. And when we look at each of these, right, barrier against infection, helps maintain fluid balance, regulates your body temperature. And again, it's a sensory organ. And anytime that skin, your integumentary system is disrupted, well, can we be more susceptible to infection? Absolutely. As far as the fluid balance, well, you get a big cut and you're leaking out blood, that can throw that off as well. As far as body temperature, and this really comes up with burns, which is why we want to recognize the thermal management. So someone who suffered a burn over, 30, 40% of their body, there's a great opportunity for them to actually become or to lose that body temperature, which is why we thermally manage these patients as well. And again, it's a sensory organ. You have nerves on the outside. This is why you can feel that when you're rubbing your arm or your leg. But that's why it's so important to make sure we do that secondary prevention, right? I don't want to fix the injury itself, but as we protect that person, wrap that injury up, it's going to help protect against all of these. There you go. I told you the lights could go off. I'm glad I gave you a warning. So now I got to go here. I wonder how many times that's actually going to happen. And I unplugged my computer. So this is there. That's a stupid thing. Turn the lights off to save energy. Well, how about when I'm sitting here and it goes off every 5 or 10 minutes? But we'll see what happens. So the problem, and I think kind of explained this well in the first 1 or 2 slides of the pathophysiology, is that anytime that there's a break in the skin, you can allow bacteria to enter the body, right? Infection risk is going to be increased, that loss of fluid. And again, the temperature control, those mechanisms can just be thrown off. So when we look at the closed injuries, open injuries, and the burns, now we're kind of getting into more of the heart of this, which is exciting. So the difference between an open and a closed injury, obviously, is an open injury, something that's pierced that skin. You can see the blood coming out of it, versus a closed injury is still an area of concern, yet we may not be able to identify everything that's actually injured inside the body. So cessation of bleeding, that's your primary concern, right? Direct pressure, potentially even a tourniquet. The next wound healing stage is inflammation. Again, and this is just, right, if you have a cut here, what's eventually going to happen? Well, then that new layer of cells is actually going to form around that damaged area. Again, this doesn't take place over the course of a minute or two, right? It could take a while for this to actually happen. You cut yourself and then you slowly start recognizing, oh, look, it's inflamed. Then it starts getting a little better. It starts to healing. Eventually that collagen provides that stability to the damaged tissue and joins that wound barrier borders, right? Now the skin actually just starts to heal back together. It's amazing everything the body can actually do. The closed injury, contusion, just another way to say a bruise, some blunt force striking the body. Okay, the epidermis is still intact, but those small blood vessels underneath are usually torn. And that's something referred to as ecchymosis, or just that darkened area you see up in the skin. The ecchymosis, again, know that term. That is just the buildup of blood that you see underneath the skin. The hematoma, on the other hand, is blood that actually collects around that damaged tissue or potentially even in a body cavity. So again, hematoma, much larger when we think about that, hematomato. But again, you see this big goose egg on someone's forehead, we would describe that as a hematoma. The crushing injury, so there's a large amount of force that's actually applied up against the body. And all of these factors come into it. It's just like, how far is the fall? If there's a fall injury, is it 5 feet? Is it 20 feet? So when we start thinking about the crushing injury, how much force was actually applied to the body? How much time was that force actually applied? And when an area of the body is actually trapped for longer than 4 hours, this crush syndrome can actually develop. When move on and look at compartment syndrome, that the swelling that occurs when those tissues are actually injured, right? So what is interesting about compartment syndrome is there is what we describe a disproportionate amount of pain, right? I might look at someone's arm and it's just gently impalpating that area, but it's just extremely excruciating. All that pressure is starting to increase inside the actual tissues itself. The open injuries, and these are awesome because I know we get to see some cool pictures on there. The abrasions, the lacerations, avulsions, and then puncture wounds in there. And there'll be something that comes up on puncture wounds about when it is appropriate to actually remove an impaled object. There's not too many occasions where we actually want to do that, but we will get to the specific ones here. When you look at an abrasion, right, rug burn, a little bit of road rash, something, but there's friction that actually rubs against and scrapes that skin, right? Some harder surface that you get on. And you can see that there's not deeper layers of the tissue that are actually affected on this. You know, we can even go so far as, well, how am I going to manage this? Well, I want to make sure I've, you know, my saline or wash that area out, put the dry sterile bandage on it, because is this area at more risk for infection now? The answer is yes. So that's why, again, we want to protect that and keep it covered. In the laceration, again, I'm always curious how these things actually happen. You asked me in class and I can tell you, because it's a little bit of a longer story, the rumors on this one, but jagged, you know, cuts that actually go for and sever that skin. Notice that we have the epidermis as well as the dermal layer that's actually being affected on this. But again, management of this, we've got some pretty bloody areas. I want to make sure I'm going to keep that pressure on it. The leg is a great area to have this because it can actually be elevated pretty easily. But again, make sure you're wrapping it up because all of those areas that have been victims of the laceration are now more prone to injury and infection. The avulsion, you actually have, you know, a piece of skin that's actually separated from that soft tissue. It could be detached, it could be hanging on as this loose piece or flap. So I like the illustration. It's great to see the wound, but then you can kind of see that picture that they give you and you can say, oh, okay, look, I've got the epidermis, I've got this going down to the dermal layer as well. So if you've got the skin, obviously you want to bring that back with you. If it's completely detached, again, just wrapping that up appropriately, it's very similar to how we would treat an amputation because that skin, person's going to want that skin back. So in an amputation, I love the definition, body part completely severed. Could be a finger, toe, could be a whole arm or a leg. But there's certain management techniques for amputations that, again, at the first part of your class, we can talk about that as well. As far as the penetrating wound, and there's a knife wound, could be, you know, gunshot wound, right? That's a penetrating wound. But we also want to think about what structures are underneath that part of the body. That too can lead to infection and eventually one of the forms of shock, which is sepsis. So again, all of the concerns are making sure we control that bleeding, but then we certainly have to make sure we have an idea of what may lay underneath that area so we can start monitoring the patient's vital signs to have a higher suspicion that this person is going to suffer hemorrhagic shock because they were shot in the area of the liver or the spleen, but all very vascular organs that, again, okay, this is going to be annoying. I'm going to run. And we'll come back. I swear, that seems like it's happening every 3 minutes right now. But hey, thanks for staying put and watching the video. The multiple penetrating injuries, when we're talking about gunshot wounds, there's potential for this ricochet. So, right, something can bounce off of here, bounces off of here. Is it a fragmented type of shell? So it's going to cause additional injuries throughout. So the thing with the stab wound was that person simply penetrated? by that knife blade, or did someone twist the blade? Did it go up and turn? Again, all things that we would like to find out once you ensure the scene is safe, but definitely an area that we have to think about. I know this came up in I think it was trauma overview as well, the primary, the secondary, and a tertiary blast, right? All just different types of blast injuries that the patient may actually suffer from. And the difference when we start assessing a closed injury versus the open injury, it's absolutely more difficult to assess a closed injury than it is an open one, right? Think about even a seatbelt mark that goes over someone's chest. Well, a lot of organs that lie there, all that force is applied, and that bruising may not be evident immediately as at scene. This may be something that you're able to start seeing when you're en route during your transport. And then is it possible, based on your index of suspicion, that now they've got bruised lungs, maybe there's a potential contusion to the heart just because that person hit the steering wheel and there was that shifting and moving of the heart itself? Did that bruise up against the sternum? So it should make sense that it's always a little harder to assess a closed versus the open injury, right? Open injury is pretty obvious and we can easily visualize that. When we look at the care for these, no special emergency care for small contusions, right? I got a big bruise on my foot. It's like this big. Ask me, I can show you. It'll still be there. But it's nothing that's going to kill me, if you will. Now, if that is something that a geriatric patient may have suffered to their head, then that index of suspicion should be, you're a little more concerned about that. Why? Because they can lead to bleeding in the brain. Is there a history of taking aspirin or being on any blood thinners? So again, just kind of an example how two injuries to two different people may be completely different. The extensive injuries, obviously leading to hypovolemic shock, that's just losing that fluid. Could specifically actually be hemorrhagic, again, depending on which area of the body has been affected. But we watch that area of the injury. And we also make sure, as we're doing our assessments, do I feel rigidity or tenderness? Is this something that happened in the abdominal area? So again, all things that we need to be aware of. And as far as a new mnemonic being introduced to you for closed soft tissue injury, again, closed versus open, we use this Rice's mnemonic: rest, ice, compression, elevation, and splinting. And think of a sprain or a strain to the ankle. The same thing with the wrist, right? A lot of that packaging that you guys were doing, I think it was as early as today, was how we would treat a lot of those closed soft tissue injuries. Signs and being aware that shock could certainly develop with this. We may see that, anxiety or agitation coming from your patient. Is this a process of pain, or is this actually changes in their mental status? That heart rate is initially going to increase. The increase in the respiratory rate. We're now looking at forms that we would call this compensated shock, right? There's compensated versus decompensated and irreversible. Maybe sweaty. Because of a process known as shunting, there could be that cool and clammy skin because that blood is going to areas of the body that need it more. And then you may actually see a decrease in the blood pressure. So care for the open injuries, and again, these are the ones that you tend to have a better view of, right? I can see it if it's open, but if it's life-threatening blood loss, I believe you all saw the thing where the guy was cut at the neck. That is a life-threatening blood loss. Again, we can't really put a tourniquet on that, but we can certainly apply that direct pressure and make sure that air doesn't have an opportunity to run in. That's where the occlusive dressing comes in, because as that outside air pressure comes in, this could create some air embolism. And so we're just trying to manage. All patients are different based on their injury, but this is just an example of the most appropriate treatments we would be taking. As far as controlling life-threatening bleed, and if you haven't been introduced to tourniquets at this point, it is certainly coming soon. There's that direct pressure, elevation. Potentially you could do the pressure dressing if that was necessary and that controlled the bleeding. But tourniquets are your most effective way of controlling life-threatening bleeds, right? Little Timmy that skins his knee in the park, I don't need to put a tourniquet on that, right? That's direct pressure, a little bit of elevation, you're gonna be fine. So it depends on the severity of the injury. Primarily, we think of tourniquets for arterial bleeds or that type of blood loss. But all open wounds should be assumed to be contaminated, and that it does certainly have a risk of infection to it, right? Anytime they're cut or that skin has been open, we're worried about that. Control bleeding by splinting it. Even if there's not a fracture, by keeping that in its natural alignment, that can be a way that we can control bleeding as well. So splinting is a fantastic skill that, again, we all need to be familiar with, but notice it's not done in only on fractures. For the abdominal wounds, and I'll give you a second to figure out what you're looking at here, as I looked at this first, I'm like, oh, the sausage is in essence coming out of the casing. So we can call this an evisceration, where those organs actually protrude through the abdominal cavity. And again, how we're going to maintain this, think about that thermal regulation. Intestines themselves, if they dry out, then they can actually die. So it's covering this with an occlusive dressing. It's managing the airway, breathing, and circulation. These are unsightly wounds, but with the right surgical interventions and definitive care, that patient is going to have a great opportunity for a good survival rate, if you will. As far as impaled objects, and this does come up, ding, 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 only remove that impaled object if it's in the cheek or mouth and it's actually obstructing the airway, or you have something in the chest and I want to stress this. I know it says it interferes with your ability to do CPR, but you have to have, the patient actually has to be not breathing and no pulse before you're going to take that out, okay? I know we've had, done this a lot of times with different classes. The object is in the chest and it interferes with CPR. Okay, patients don't always need CPR, right? Who needs CPR? You're not breathing, you don't have a pulse. That's a person that needs CPR. So just because that knife may be embedded into the chest, don't take it out unless they're not breathing and they don't have a pulse, right? When things are impaled into someone, it creates a process that's called tamponade. So generally when that impaled object is in the person, it's actually resting against some of those blood vessels, and you pull it out, then it can actually make that bleeding even worse. That's why we tell you, don't pull out impaled objects unless there's an absolute need for it. And then you saw those two occasions that it's deemed absolutely necessary. For the neck injuries as well, the open veins may actually suck that air in, or an air embolism that leads to the cardiac arrest. Using an occlusive dressing in that area is great. And as far as manual pressure to compress that, but you can't compress both of the carotid arteries because that's the blood that's going to the brain at the same time. So it may have to alternate. And again, just a light pressure so you don't inhibit all of the blood flow that needs to get up to the brain. Different bites, again, that's an open injury. Depending on what the person was actually bit by, you want to get them evaluated, right? And these, we think about small animal bites. It could be more of a mauling from a larger dog. And there's this nasty bacteria that's actually in, that dog's mouth. Same thing goes with human bites as well. So again, we want to make sure they're checked out. Maybe we clean up the wound, and then they end up needing some form of antibiotic for that. But major concern, stop the spread of rabies. Again, and this is why we're going to take those patients to the hospital. The human bites are nasty. Again, told you that on the last page, but making sure that if it has actually penetrated the skin, then those are serious injuries, right? They can have this spread of infection. Again, they've opened up that skin, but we're going to clean the wound as best as we can, all right? Dry, sterile dressing, immobilize that with a splint in the natural position for the patient, and you transport them to the emergency department. I know we look at these injuries and that doesn't often equate to the big open injuries that we saw, but It's actually more concerning because of that risk of infection. Humans are nasty things and their mouth is nasty, and now all that bacteria could be spread to that person who suffered that bite. So as far as burns go, and we'll see the different degrees, the first, second, third degree with your burns, but these have got to be the most painful of all injuries. I definitely agree with this. And if you need to define a burn, it's when the body receives more radiant energy than it can actually absorb, right? You can take so much, but eventually, as that is increased, they're going to have damage to their soft tissue. So it's a complete assessment just to make sure you haven't missed anything. Had someone who fell into a fire and, you know, it looks like it's just this part, but he actually had soft tissue and open injuries on his legs as he was cut against some glass as he went down. Yeah, your airway, breathing, circulation are your primary concerns. I'd call those more of secondary injuries that we found on the legs, but they're still concerning, right? If I don't control that bleeding, eventually that's going to lead to that uncontrolled insanguination, and they'll die of that. So children and older patients, children and older patients, so geriatrics and pediatrics, more susceptible, right? Shock from these burn injuries. Why? Just think back to that thinner skin that they actually have, and it may not take as long for that to burn down to deeper levels, and then it allows more fluid to be lost. And so that's why that correlation is there in the children and the older patients. Chronic illnesses, again, diabetes is really rough. And again, as they experience that shock, where they can experience shock from burn injuries, just because there's less overall good circulation, or the skin is thinner in those two groups, and it doesn't have to be exposed to the same heat source as long. Pathophysiology, there's soft tissue injuries, right? Soft tissue injuries, we're still dealing with those, but it could be the transfer that's radiant, thermal, or electrical injury, right? We can have electrical burns, thermal burns, radiating burns on that, or radiation that causes it. Thermal burns when that skin is exposed to temperatures above 111 degrees. That just jumps out at me as something that may be on a test question in your future. The severity of the thermal injury, well, it depends on a couple of factors, right? Temperature, it was 114 degrees, okay. The concentration, the amount of heat energy possessed by the object or substance, right? How big is this as it's coming to them, and how long or duration was it actually exposed to that person's soft tissue, right? All these factors need to go into a burn. The greater the heat injury, the deeper the wound, right? So if I put that 112 degree thing on my skin, but I pull it off immediately, there's exposure time, then it probably just burned that first layer of the epidermis. Now, at the same time, I take something that's 200 degrees, I put that on my skin for 5 minutes, right? It's kind of like putting a knife in the butter. If you do that for just a little bit and it's warm, it may just go through just for a brief amount. But keep that on for a lot longer period of time, and right, it just keeps going down. It's being exposed to those deeper layers of the tissue. As far as people reflectively limit heat energy and exposure time, what that means is simply if you touch a hot, I was curling my hair the other day, and right, it hit the scalp, and you pull that off almost immediately. But those things are so hot, especially the flat irons, that as you do that, it can still burn just that area of the skin. But imagine leaving that on for a longer period of time, how much more damage that could actually do. What's going to complicate your burns? Well, the skin, right? That's your barrier, and now it's open, right? We've destroyed that. When you think of the things that burn victims are most susceptible to, again, there's infection, same thing, because your integumentary system has been destroyed. Maybe we'll just teach this in the dark right now, because you don't need to see me so much, you need to see the slides. So there's more risk of infection. The hypothermia, because the body's regulatory mechanism has, of course, been shut down because you've ruined that skin. Hypovolemia, just that ability to lose more fluid, and shock. Burns are some of the easier ways for people to lead to this hypovolemic shock. There is something, and if you're curious, you can look up the Parkland Burn Center formula. Just has to do with the body surface area percentage that's actually been burned, how much fluid that person's going to need over the next 24 hours, and then it's titrated down. But burns are just things that can cause some really major issues for patients. Significant burn, we start worrying about the airway, right? They suck in something that's a heated gas or from a flash that has that potential to damage your airway. Circumferential, meaning it goes all the way around. As that swelling increases, it can decrease the ability of that person to expand and contract their chest. Any area or extremity, such as the arm, the leg, if it's a circumferential burn, it means it can basically act as a tourniquet. Tourniquets are great because we can actually release those, but a circumferential burn is something that, again, do they have to do cut downs? How are they going to actually relieve that pressure in the person? So again, those are what we list as a more severe type of burn. Now, burn severity, it's going to depend on a couple of things, just like we have with the open or closed injuries. The depth of the burn, right? How is it a first, second, or third degree? Is it, over 2% of the body, or is it over 20% of the body? Is it at critical areas, the hands, the feet, the genitalia, the mouth, right? Those areas all decide how severe this is. Are there pre-existing medical conditions? And then patients younger than 5 and older than 55. Those are just two areas that might have those thinner layers of skin. And the pre-existing conditions, though, I always want to think about that when we're dealing with any type of trauma patient, just because those can definitely play a role in how well that person's going to do in recovering from this. So the first, second, and third degree burns also have, I'm just going to say names in addition to that, but superficial, partial thickness, and full thickness. How we recognize a superficial burn is just that redness to the skin. When you get into partial thickness or second degree, that's the introduction of blisters to that area. And a full thickness is the actual charring of the skin, the third degree burn. So here's the actual charring when we start looking at that third degree burn. Second, he's got some blisters forming here. And even a sunburn can be potentially a bad burn, right? When you look at this little bikini thing going on, and I got to think there's the same type of setup on the top, but potentially that is easily 90% of that person's body has suffered that first degree burn. So that can still be bad, even though we say, oh, it's a first degree. When it's covered over the extent of that body, then it becomes more severe. If you've ever had a sunburn, you know that you can start leaking out that fluid. Again, that's just something that you have to worry about. Second degree burns, notice the blisters here. But on a third degree, we see these areas of charring. But what else does a third degree burn have with it, or that full thickness, is it has first and second or superficial and partial thickness burns with it. So technically it's not painful in the area of a third degree burn, but since that entire area is also surrounded by second and first, that's why they say these are extremely painful for your patient, because any third degree burn is going to have a second and a first degree with that as well. And you know how painful burns actually can be if you've had one of those. The rule of nines, or a Palmer method. The Palmer method is using the patient's hand to identify 1% of their body surface area, BSA, body surface area. They are different for infants, children, and adults. And so I know there's a little scale that comes up here, but include only partial thickness and full thickness in the estimate and the burn, or the extent of that burn, okay? But that doesn't mean someone that's got that 90% first degree burn, we wouldn't describe it as that, but these are just dealing with some of the really bad burns when you use a rule of 9. And so here's just that scale for you. And we'll spend more time on the rules of 9. That's just that overview of how we would describe this patient's burn. I'm just thinking back to that slide we saw of the full thickness burn, or that third degree, and it definitely had the 18% It looked like his chest was burned, the arms were burned. So can we say that was a 36% body surface area burn for that patient? Well, not really, because I couldn't see the rest of the picture, but that gives you an idea of how that rule of 9 works. If the patient has, again, that arm is burned, maybe it's this 9% that we're concerned with, but that's just a way to describe how much body surface area has been affected. And the Palmer method, it's not your hand, it's equivalent to the patient's palm as you would put that over. So conceivably 18 of this guy's palm is going to cover 18, or 18 would fill in his chest portion. It's not an exact science, but it gives you an estimate of that burn that he has suffered. So classify the victim's burn, absolutely. If you can, right, what were they burned by? How deep is that, first, second, or third degree, you know, and severity. So these are all, you know, fortunately, you don't have a lot of burns. We get a lot of sunburns, first and second degree burns from that. Water blisters on the person's chest or something, great. But it will take some practice and confidence getting comfortable with the Palmer, and then, of course, the rule of 9s. Thermal burns are caused by heat, right? Thermal burns, radiation burns, and we could have these electrical burns. But it could be a scald. There's an open flame, right? What happens? Someone pours water on their chest. They didn't mean to, but they knocked that off the stove, and bam. That's how these thermal burns often happen. It could be there's hot objects. Again, I do this all the time. I only cook with cast iron pots. And a cast iron pot is awesome, but it also conducts that heat very well. And so that something like that, small burn. Why? Because we tend to pull that stuff off quickly, right? I don't leave my hand on the cast iron pot until it continues to smoke and burn. You take that off immediately, those are your reflexes, and that's why that can be delayed. And obviously someone who doesn't have that same functioning or capability. Steam burns, and these are thermal, but it could be a scald. It's also the radiator that happens, and a flash burn, some type of explosion, but again, that is a process of a thermal burn, that heat that's being released from it. So management, what are we gonna do for it? Again, just first and foremost, stop that burning process, right? Cool the area, but you notice the jewelry needs to come off as well, because that area of the tissue is going to swell. High index of suspicion just means we're concerned that that person could have, you know, taken some of that gas in, and then you've got the trachea, which could actually start swelling. So we're always listening for hoarseness, or they got some coughs going along with that. That could be an indication that they actually sucked in some of those gases. But dry dressings applied to the areas that are actually burned. Inhalation burns, enclosed space without ventilation. Again, even a barbecue when they're outside and that thing goes up, it can happen that way as well. But your upper airway damage, inhalation of these superheated gases, lower airway damage associated with the inhalation of chemicals. Again, there are different types of chlorines or cyanides that could lead to this. But then we're going to get into decontamination, so we'll hold off on that one right now. But the severe upper airway swelling needs intervention. And this is where, as you're starting to go through those medical and trauma sheets, you know, ALS, again, we're all going to start with basic techniques first, but it could be someone that needs to be criked or have a different access to that airway that BLS alone isn't able to provide. There, again, in burning, the combustion process, there's, you know, benzene rings and just different gases that come out with that, but those are all toxic gases to that person, again, which is why we would start with a fresh air setting, but then provide them with the supplemental oxygen. Carbon monoxide, and carbon monoxide has this affinity for the hemoglobin and push the oxygen off. But when you start thinking of what am I responding to, you have 6 people in a house and they all have got this, you know, headache or nausea. That's a lot of time where carbon monoxide can be present. So again, getting them out, a fresh air setting is most highly recommended. Hydrogen cyanide, again, just generated by combustion, that burning process that's going on creates toxic gases and fumes. So what are we going to do for them? So obviously we want to make sure that as far as pre-hospital treatment is concerned, that they need to be decontaminated, right? We don't want to take that stuff into a hospital. And we'll do much more on decontamination, but decontamination and supportive care, right? Position of comfort, oxygen, and then of course we're transporting any gas or toxic gas exposure. And this is where we start to refer to 704s or placards, recognizing it, right? Need to know what they were exposed to so I can identify it. And there are different treatments potentially for these gases. Your primary concern is to get them out of that environment and supplemental oxygen. Chemical burns and chemicals that come in contact to the body. This really doesn't, it talks a little bit about the acids and the bases that are out there, or the alkalis. Acids tend to give you more warning properties. Ooh, I get acid on my skin. Ow, that hurts. But bases tend to, they can be on the skin, and it has to actually eat through the epidermis first before you may actually contact that. So as we look at decontamination, again, making sure we're rinsing this stuff out for a 15 to 30 minutes as we have to irrigate these sections of the body. Eyes, extremely vulnerable to that. So again, making sure we have eye washes, and there's things called Morgan lenses that can help us get this out of someone's eyes. Severity of the burn. Again, what was it, right? How much of the chemical was in there? We can dilute, muriatic acid so much that you can actually put it in a swimming pool, but that's got X amount of thousands of gallons versus, a quarter cup of this acid. And if that acid were to be splashed directly in the face, that's what I mean by concentration of the chemical. And again, how long was it that they were actually exposed? Did they get in and start rinsing their eyes out immediately? But there should be some chemical resistant gloves for this, as well as your own eye protection, because whose safety comes first in all of this? Oh yeah, it's me, it's my partner, it's the patient. So again, make sure you're keeping yourself safe if you are dealing with these. I swear this picture has been in the book for a long, long time. I think I remember seeing it in my textbook before y'all were born. So if there is a dry chemical, hey, this always comes up. If there's a dry chemical, make sure it's brushed off first. Certain chemicals can be water reactive. So if I just start to irrigate that person and that chemical happens to be something that's reactive, it can actually cause more burns. So that's why I say we want to make sure that you brush that off the skin first before flushing the area with water. And this may be, you may be providing that immediate treatment, but fire department shows up or that decontamination unit, that's where that would be completed. But patients like this it is required, remove the patient's clothing, right? And maybe there's some Tyvek suit you can put them in afterwards, but it can stay on the clothes. So that is something you could take into the hospital. So we want to make sure we get all of that off as we can. For the liquid chemicals, again, flush a burned area. Copious amounts of water is an appropriate term for that. Flooding the area 15 to 20 minutes. Again, you want to make sure that burning process is stopped. And if you can find out if it's an acid versus a base, that can tell you how long you may actually have to irrigate that for. And this is, again, this comes up later. I know we're in trauma, but MSDS's material safety data sheets that, again, tell you about the chemical and the best treatments for it. But to say proper decontamination, you do not want to take a contaminated patient actually into the hospital where you now shut down that entire emergency department. For electrical burns, the body is a great conductor of electricity. So we want to make sure that, you don't touch that person if they're still in contact with the wires, right? That's just going to allow that current to flow directly into you as well. There you go. You're a good conductor. Now, what it was and, how many amps or that current that was directed into that person can cause these real serious burns. It can also lead to cardiac arrest. And so if you're responding to an electrocution, we want to make sure that it is, your AED is there, it's on scene as well. But your safety, again, comes up first. As far as the burn injury, appears where the electricity enter and exit the body, right? Maybe I can't tell the difference one versus the other, but your concern on this at this point is there's could be some deep tissue injury. It can also affect the cardiac and the respiratory system itself, right? You are a big ball of electricity. You got this, sinoatrial node, AV node, Purkinje fibers, bundle of His. Those are just specific parts to the heart. But when that electricity is introduced to the body, can actually throw that out of whack really easily, which is why we always say, hey, I should probably have the AED. Look at how much damage that's actually caused to the tissue, right? Am I looking at third-degree burns here? Do I have second and first? But there's entrance wounds, there's exit wounds. Again, if the person isn't able to communicate with you, think about what we do in trauma, right? We expose so we can see any of those potentially injuries, see any potential injuries on the patient. So vindicated, I would say if indicated first, make sure that you are safe, right? There's lockout, tagout, which turns the power off, and you've guaranteed that power's off. So that's got to be done if you're entering that charged electrical environment. So if you need to, you start CPR, but get the AED on as quickly as possible. If they don't need CPR, we'll provide that supplemental oxygen. Again, defibrillating someone who's been electrocuted generally within the first 2 minutes is their best form of treatment. And as time goes by, it just tends to decrease their chances of survival. So how do you treat the soft tissue injuries? Just, again, that dry, sterile dressing. But where's definitive care going to take place? It's at the hospital. So again, prompt transport, immediate transport of that patient. As far as tasers go, law enforcement increase the use of tasers. Okay, there can be some patients that have underlying issues that this is, tougher on them. It can lead to dysrhythmias and cardiac arrest. Put the AED on, right? The AED is the thing that is, if you find someone that, they were hit with the taser and now they're not breathing, there's no pulse. Well, what would we do anyway? We'd go straight into CPR and we'd put the AED on. So it's kind of just common sense approach with any patients that you're dealing with. Radiation burns. And the thing with radiation, that people that are in the transportation field or certain, chemical plants that they have out there, those are obviously at higher incidence for this. Me and Joe Schmo, who are just going to the grocery store, probably not as many incidents of that. But intentional release, radioactivity, and terrorist attack, it's really hard to disseminate radioactive materials, but I guess it could happen. And this kind of leads into the weapons of mass destruction, some of the last chapters that you'll actually do. But if there is a radiation exposure, again, you need the hazmat team there. We need Geiger counters. We need to see how much of this is and what it actually is. There's 3 types of the ionizing radiation from the alpha, beta, and gamma rays that we're concerned with. Uh-oh, now I got to go back. Man, I was doing so well. We're living in the dark here. There we go. Now I'm back. I got it. Stand down. Most ionizing radiations involve gamma radiation. Those, again, are X-rays. As far as your management, you're approaching these seams. And I got to say, if the nuclear medicine department at the UMC down in the basement goes haywire, that should be a hazardous materials response, right? If you're accidentally walking in this area and people are just dropping left and right, well, you need to get yourself to a safe distance, and you need to make sure you call for that backup in your hazmat. But we can take the people out of the area where it's safe to actually do so, irrigate the wounds, and obviously notify the emergency department of what type of incident you're actually having. They may set up certain decon tents for radiation, so we don't, again, bring that directly into the hospital. But the greatest way to prevent yourself from those, X-rays or alpha, beta, gamma rays, time, distance, and shielding, right? Time by limiting your exposure. The distance, I want to be as far away as I can. And then, of course, the shielding between any of those potential rays out there. The bandaging, and these are some of the things that I'm pretty sure you were practicing, be it the sling and swathe We're looking at the sterile pads and how we actually do the dressings on the patient. What do we use these things for? Well, we control the bleeding, protect the wound from further damage, and then prevent further contamination and infection, right? That's why we put these bandages on. So kind of goes in line with how this module or chapter started about, oh yeah, let's make sure we don't let infections, the skin is broken, we got to protect that. So we'll make sure we put our bandages on, that we don't want them to bleed anymore, so we can put that on, potentially apply pressure or the tourniquet. But that is the whole idea of what our bandages are. And you'll go through these and see the bandages themselves. This is something that's best done in person. We're looking at 4x4s, or again, just different size gauze pads that we have. The appropriate for smaller wounds, again, we're talking just the little pads, a 4x or even a 1x, depending on the size of it. The adhesive dressings, those are just minor wounds, right? We put that on. The occlusive dressings, that's a big difference, right? That wants to prevent air and liquids from entering or exiting the wound, right? So I guess if we know the gauze pads, little small things that we put on, adhesive types, again, you got some minor wounds, but an occlusive dressing, again, because I know you'll hear the term constantly through this chapter, occlusive dressings prevent that air liquids from actually entering or exiting the body. More bandaging, keep your dressings in place during transport. Yes, if someone continues to bleed through those bandages, then make sure you put more on. Don't take one off, which will interrupt that clotting factor. So again, we can just put more bandages on. Adhesive tape holds small dressings in place. So this is just your little tape that you have, paper tape, but don't use the it's Coban or an ACE bandage to secure those dressings, right? That just doesn't have that room for expansion, and we can make that too tight. But this is what I was talking about the last point. If the wound continues to bleed, despite your pressure dressings, then that's when you can consider a tourniquet. If it's just oozing through and you notice you have to put more bandages on, that's great. But there's a big difference between putting a tourniquet on and just making sure you have to apply more dressings to the patient. Arterial blood loss is typically the only time we're really going to have to utilize that tourniquet. So thanks for bearing with me in the dark. I just didn't want to start this over. And I know we owed you this lecture from today, which is why I've finished now, and I'm going to go do the night class. So we will see you all on, I don't know, there's so many different classes here, next time you're here. So thanks.